I will present this talk. It is based on a freshly published paper. It is published in the beginning of the current year. The reference will be in the end. The basic topic is epistemic injustice, temporal aspects of drug dependence, and the link between the two. Okay. My talk is divided into two parts. On the first, I will introduce the concept of epistemic injustice, the epistemic injustice related to healthcare and specifically to care with people having drug dependence. And the second part will be dedicated to specific subtypes of epistemic injustice that people with drug dependence are affected. And our main point with Alexei, that these two subtypes of epistemic injustice, very prolifically covered by academic literature, they are not enough to speak about the whole spectrum of epistemic injustice related to care, healthcare, when we're speaking about the people with drug dependence. So, very abundantly cited work of Miranda Fricker, called Epistemic Injustice, introduced this concept, very basic for bioethics, medical humanities, very well discussed right now. And there she introduces two basic types of epistemic injustice, testimonial and hermeneutical. I think anyone of us have a possibility to grasp these reasons, because any of us was a subject, or I would not like to use this word, but a victim of these two types, these two forms of epistemic injustice. The first form is testimonial injustice. When the person raises her voice, but she is not heard well. So it is like negative bias, negative stereotypes towards people who are testifying. Fricker uses Killing the Mockingbird plot as an example, as a basic example, where African American is testifying in court and no one is hearing his testimony because of his skin color. So it is about the negative stereotypes that blocks our ears from hearing someone's voice, or eyes from reading someone's text or as a testimony. The hermeneutical injustice is more complicated, and it is more abundantly covered in the academic literature, because there are so many ways to misunderstand one's hear but misunderstand one's own testimony, that yes, I'll try to. Sorry, multitask is
my fault.
is not my strong side. Okay. Fricker uses example. She has plenty of examples, and we have plenty of examples, of course, in healthcare, because any personal experience of sickness, of illness, is individual, and it is really hard to completely understand and make some clinically essential inputs from one's own experience, for example, for healthcare workers. It is a big task to understand them well, but Fricker, she starts with very simple plot where like old-fashioned boss is hearing the complaint of his woman coworker who is complaining for sexual harassment. But he, as he is like very old-fashioned, he don't understand this. He has no this concept. He knows the word, but he have no concept. He have no any meaning under this. Okay, he asks, is it was it rude? Was it like violence or something? And this lack of concept leads to what we can say hermeneutical injustice, because then it leads to nothing. So there are two types of breaks in the communication: testimonial and more complicated. Okay.
Just click on the.
Yeah. Okay. No. No. Then I'll try this arrow. No. Still. Okay, so I can change. Uh, so there are some sources about the temporal aspects of epistemic injustice in general. I'm speaking in general right now, not in the framework of healthcare sciences, but the general framework of epistemic injustice, the temporality of these can result from unconventional manner of representing one's temporal experiences. So the people who are hearers, they can't grasp the meaning, or the mismatch led by some dominant temporalities. I will cover these 2 points later, but we can make this clear about drug-dependent patients, like through negative stereotypes and through their problem of uh, describing the whole complexity of their temporal experiences during the caring procedure, while it can be essential for caregiver to understand all these peculiar features. There is a very huge and super interesting, I would like to say, literature about different temporalities of people using drugs and people with drug addiction. So mostly addiction is understood as a disorder of temporality. And there are different meanings of this disorder. Like a person can try to escape from the linear, dull, routine temporality. That is the basic, very simple or simplified understanding. And the other understanding is that uh, social structures, social injustice creates some locuses in the social structure where person cannot synchronize well, cannot handle with different forms or sides of social life. The main issue when I spoke to like sociologists dealing with this problem. The main issue, healthcare issue about people using drugs was not the type of drug or even not the dose, but the significant predictor of their socialization was the ability to manage time, to manage their different temporalities, to travel through what is people using drugs call fractal time, fractal temporality. So this is fractal is very complex structure, and you can easily transfer yourself from one side uh, one part of this temporal structure to other, making a very short step, but you can travel, you can live in one temporality for long period, like because fractal gives you a possibility to move like in a spiral manner, very, very long. So it's like just general points to understand the depths of the problem. Uh, so now we're going to more specific topic. What we are trying to highlight in our paper. Uh, Three temporal dimensions of epistemic injustice. Two, you already know them, like testimonial linked to negative stereotypes about temporal features of human cognition. Uh, Hermeneutical linked to lack of hermeneutical resources, like someone misunderstand what people are referring to, even if they're very um, precise, describing their temporal experience, their daily routine. But yeah, it's really hard to understand. Of course, because you don't have probably the comparable experience of this time. But there are different, whatever, to have a step, as to make a step aside and make a remark. The basic authors are writing about epistemic injustice in healthcare, Heather Carroll and Jan James Kidd. They are very specific about underlying that in the situation of epistemic injustice, there could not be an unjust person. So no one can be blameworthy despite epistemic injustice occurs. It can be based on the very specific character of one's experience. And therefore, there is no like epistemic resources. There is no words to describe what a human being is feeling. So if there are no comparable narratives, person can explicitly lack the words, the terms to describe what she or he is experiencing. And the third dimension of epistemic injustice is temporal mismatch in interaction with healthcare system, what we call desynchronization. It is very easy. I will go deeper into each type, but it is very easy to understand. So we can close the door and make this room epistemic unjust place. So no one will come. The situation of communication is blocked. So, or we can make it opened in the time where, when I, for example, can travel here, like in a reasonable, comfortable manner from Bochum, and therefore it will be epistemic unjust towards me, towards myself. So you can move your presentation, for example, super early in the morning or super late in the evening, and therefore I think there would be much less amount of people than I can see. And of course, for the lecturers, it will also unjust. And therefore, I will not have a possibility to make a testimony about different kinds of epistemic injustice. So the first is giving a possibility to a person to raise her voice, to have a communication, to seek the care. Okay. So we are going deeper into different sorts or subtypes of epistemic injustice. First is testimonial injustice linked with stereotypes about cognitive processes. The main our source here was the bioethical literature, bioethical discussions, and like normative oriented literature in medical humanities. So there is a stereotype that addiction is not a disorder of temporality, but a disorder of desire. So here I would like very briefly highlight Harry Frankfurt's very famous and basic author in moral philosophy, in analytical philosophy. He points out that we have like everyday desires. Like right now, I want, for example, eat some sweet because my cognitive process are rather active and they need sugar. But I will not go out and look for vending machine or something else because I have a second order desire to make this presentation because it is part of my like academic activities, and that is what or who I am, an academic making a presentation, not a person who wants sugar. So our second order desires, our desire that control first order desires, makes us persons that we are. So if we apply this to addiction, it seems rather easy to make an inference that people lack this capacity to control. They lack the power of higher order, second order, true desires to give up, for example, drug abuse. And there is a very interesting paper called Cynthia's Dilemma, called after women. She was a drug user, and where the quote was, her quote was like, "You can't do anything if you want to use or misuse heroin. You can't say no to the stuff." And therefore, it is a big issue for healthcare workers to understand where their decision for healthcare professional, it is essential to understand when the person, for example, with some cognitive disorder and or mental disorder and addiction is, of course, one of the parts of the classification of mental disorders. When this person making an autonomous decision and to discriminate when like the person is not autonomous, for it's also applicable for average person, like person can be drunk and sober, and not all decisions that are made by drunk person are really wise, are really the second order desires of a person. Sometimes drunk people are doing just they want to do at the moment. So therefore, it was a big discussion. But when the social research started, and Julian Savulescu, a very prominent bioethicist, he's referring to them. Sociologist spiked that mostly even addicted person are capable to make autonomous decision. There is a very tiny moments when the desire to misuse drug is stronger than their second order desire to have a well socialized life. So there are different pictures of how this mismatch can occur. One is synchronical mismatch, as in Frankfurt's case. So I have first order desire to eat sugar and second order desire to have election at one single moment. And I prioritize second order desire. But there could be a big time gap between my formulation of my second order desire and short first order desire to, for example, to misuse drugs for people with drug addiction. So it can be desynchronized, and therefore we can speak that mostly these people are capable to make autonomous decisions. There is super tiny moments when they can't, and we can discriminate them. So Savulescu and current bioethical consensus is that people misusing drugs, they're capable to make decisions about their course of care, of health care, of therapy, and so on. So I hope these stereotypes are now mostly broken, at least in the best practices of care or in academic literature. Of course, I think the situation is very different, even if we are speaking about low or middle income countries, about the lack of healthcare resources and so on. Okay. Now we're going to hermeneutical injustice. I think this course have plenty of lections about phenomenology in healthcare and hermeneutical interpretive procedures of first-person experience, how we can deal with this. It is super interesting. It is most complicated, and the most researchers are concentrating on this very complex, but also very interesting topic. Our example is Zimbardo's scale, Zimbardo's inventory about time preferences. And the point is very simple. This time scale is based on assumption that of time linearity, that the day after tomorrow is more distant from me than tomorrow. But for example, if I have very essential meeting on the day after tomorrow, it will be, of course, closer to me. The time is not linear if we are thinking about planning. I can have no plans for tomorrow. I can even not be disturbed if like tomorrow anything will occur or will break my plans, for example, to have a walk in a park. But of course, I will feel nervous, even if some tiny phone call will break my concentration before the meeting on the day after tomorrow. So the time is not linear. And if we base our scale, our grading procedure on this assumption of time linearity, we are unjust towards people with very different non-linear time frames. Well, I would like to say, I think any time of any person is not that linear as they making an assumption, because it is basically taken from behavioral economy on the game with children. Would you like to have a one sweet today or two tomorrow? So it is supposed that it is more wise to prefer two tomorrow or four on the day after tomorrow. It is it is well criticized notion of rationality, very, I think, based on free market assumptions of good behavior. Therefore, it is other very interesting topic. But the point I hope here is clear that we shouldn't use some instruments for making clinical decisions or for assessing the progress of therapy that are based on very oversimplified assumptions about time, especially when our disorder that we are dealing with is a disorder of temporality. And now I'm going to the last, but not least, sort of injustice. It is, we can't classify it well, because how it is mainly written about in academic literature, and it is not only testimonial injustice, it is not a hermeneutical injustice, but the blocking a possibility to communicate, blocking a possibility to look for a care through the desynchronization. It is also a structural injustice that have obvious epistemic consequences. So the main driver here is not stereotypes, is not the lack of hermeneutical resources, or better to say hermeneutical practices, because even people writing about epistemic injustice in healthcare, Carroll and Keat, they are making point on hermeneutical practices, that it is a process of interpretation, not dealing with some pool of concepts that you have, that doctor can have in their tables. No, it is a big procedure, a big process. So if you block even the possibility to start this process of communication, testifying your experience and interpretation, then you are also epistemically unjust towards some sort of people. So there are two sorts of literature on this type of blocking the testimony. One is more like having larger focus on free market economy, temporalities of everyday routine, the precarity, how we are supposed to handle with different sorts of activities, and of course, feminist literature about women's caring routine after their labor time. So the other labor time after like wage labor time. And there is also some very specific research about how people, especially refugees, are struggling seeking healthcare, for example, methadone replacement therapy, when they came from one part of the world to the other. So it can be very obvious that the caring institute is closed after the working day, or it is located so far that you can't travel there for every week. And if you receive a weak dose of this replacement, then it is very hard for a person to stay socialized, to be adhere to this specific therapy. So there is a desynchronization issue that we are trying to highlight, and we are trying to yeah, just- and we are trying to make a final point. It is not very elaborated recommendation, but it is just, I think, can be extracted from the common sense intuitions. So to make this room epistemically fair, first we need to open the door, to make the door opened, not to discriminate people who want to enter and who want to communicate about some issue. So it is the first issue. So desynchronization is the first issue. The second issue is, of course, testimonial injustice. We need to hear the voice of a person, for example, not completely understand, because not all in healthcare, not all in first person experiences and narratives is like very transparent, very easily to understand. It is not logical schemes. It is very, uh, very personal and very indirectly testified things. So, but at least you should try to hear, to be testimonially fair, testimonially just person. And then after all of these, we can address hermeneutical practices and resources, the topic that is mostly covered in very abundant literature in medical humanities. And if the order is opposite, I liked the title of very fresh David Ludwig's paper. He's a researcher in science, technology, and society in Netherlands. That okay, we shouldn't mask structural injustice by the rhetoric of epistemic injustice, which is sometimes occurs. It is not, we can't just make more epistemic resources, make them viable, like publish a book on specific experience of a specific group of people using or abusing drugs. But we should first look how structurally just, how structurally fair we are towards these people. And of course, epistemic resources is not a compensation for person who can't afford their rent. So thank you for your attention. I would like to go to the discussion round.